Hello, I'm David Winchester, and I am here to present another case from the Referring Wisely campaign. We're going to talk about nuclear cardiac stress testing in patients with peripheral arterial disease. The case is a 62-year-old woman. She has claudication in her right leg when she walks more than 100 feet. In clinic today, she says that she has no angina, no dyspnea, no other symptoms suggestive of coronary disease. Medical history is remarkable for hypertension and diet-controlled diabetes. She does continue to smoke 1/2 pack of cigarettes per day, and her current medications include hydrochlorothiazide at 25 milligrams daily and omeprazole. On physical examination, she is hypertensive with a blood pressure of 165/95 and a pulse of 83. Her BMI is 33. Cardiac exam reveals a normal rhythm with no murmurs. Lung sounds are clear. She has diminished pulses in the lower extremities, worse in the right lower extremity than the left. ABI is performed in the office and reveals a right lower extremity value of 0.67, with the left leg being 0.92. The question is, should this patient undergo nuclear cardiac stress testing to screen for occult coronary artery disease? In reviewing the literature, we can find abundant evidence demonstrating that patients with atherosclerotic disease of one vascular bed frequently have atherosclerotic disease of other vascular beds. In this example, from a series of cases that was published in 2016, 64 patients underwent whole-body vascular MR when they presented with symptomatic peripheral vascular disease. One patient from this series who had symptomatic peripheral arterial disease was also found to have a 50% stenosis of the left internal carotid, a 70% stenosis of the left renal artery, an occluded left superficial femoral artery, and evidence of late gadolinium enhancement in the myocardium, suggesting a prior asymptomatic inferior myocardial infarction. Additional data that was published in 2015 demonstrates the high degree of both prevalence and overlap of vascular disease in patients in the United States. Some 8 to 12 million Americans are estimated to have peripheral arterial disease, with a prevalence that increases with age from 1% at age 40 to over 15% when the patients get into their late 60s and 70s. Looking at the red circle on this illustration, we see that proportion of patients with peripheral arterial disease, some 61% also have either coronary artery disease, cerebrovascular disease, or both. We also know that in patients who have claudication, they have significant risk of cardiovascular events. But interestingly enough, it is the cardiovascular morbidity and mortality that significantly exceeds the limb-related mortality. In this chart, you can see where MI, stroke, and mortality are some 10-fold greater risk than critical limb ischemia. If we consider this significant cardiovascular risk and apply the appropriate use criteria, the most applicable appropriate use criteria indication in this case would be number 11, which corresponds to a patient with high global coronary disease risk. And in this case, our patient is unable to exercise due to her claudication. In such patients, stress radionuclide imaging is rated as may be appropriate. If we also consult guideline management recommendations for patients with peripheral arterial disease and claudication, we see that statin therapy, tobacco cessation, antiplatelet therapy with aspirin, and optimization of diabetes control are all recommended. These, of course, are the same recommendations that we would offer to a patient with cardiovascular disease for primary or secondary prevention. So given the appropriateness rating for testing and the significant overlap between guideline recommendations for patients with claudication and those with coronary artery disease, in my opinion, stress testing is not necessary for this patient, although it could be performed if after having a discussion with the patient it was felt to be in their best interest. In this case, the more valuable interventions would be to focus on reducing the patient's cardiovascular risk by encouraging her to quit smoking, to lose weight, to initiate statin and aspirin therapy, and get better control of her blood pressure. In this case, an ACE inhibitor could be added given her concurrent diagnosis of diabetes mellitus. It would also be important to make sure to address her symptoms. In this case, I would start with an exercise program and also consider medical therapy if that proves ineffective.
Hello, I'm Dr. Gretchen Deemer, Associate Professor of Medicine in the Division of Hospital Medicine at Thomas Jefferson University in Philadelphia. I'd like to share my thoughts on this patient. She is a 62-year-old female with symptomatic peripheral arterial disease manifest as claudication. In this case, we are not given any symptoms of coronary artery disease and must decide if additional cardiac imaging would be useful. We regard her peripheral arterial disease as a coronary arterial disease equivalent, so we choose the appropriate use criteria table for high global coronary artery disease risk, number 11. It lists multiple tests that may be appropriate. This doesn't mean they are automatically recommended, and to provide the most high-value care to our patient, we must decide what question would these tests help us answer. As Dr. Winchester points out, there is a high chance that this patient has underlying atherosclerotic disease in her coronaries, so a positive test will only confirm what we know. Additionally, the treatments for peripheral arterial disease are the same therapies we'd reach for to treat coronary disease, so a positive test would also not change the medical management, including aspirin, statins, smoking cessation, and improved blood pressure control. I'd also ask you to think about what a negative test result would tell you. All of the tests that are listed as maybe appropriate have some false negative rate. It's low, but not zero. So a negative test may not completely reassure you that she doesn't have coronary disease, and you still would need to treat her peripheral arterial disease as described before. As Dr. Winchester described, there may be specific cases where one of these tests may give you more useful information, but I agree with him that the routine use of cardiac imaging in cases like these is not high-value care.